All right, it looks by my clock, which I hope is right, it's now 12 o'clock and we're going to begin today's presentation. My name is Mark Womack. I'm the Community Development Coordinator for Parkinson's Society Southwestern Ontario, and I'd like to welcome everyone today to PSSO's latest webinar, Welcome to Sleep Tight, Nighttime Issues in Parkinson's with Dr. Mary Jenkins. Dr. Jenkins is on the line with us and is a great friend to PSSO. We're so thrilled to have her working with us and helping us out through doing seminars and webinars such as this, and have her experience in order to answer questions and help our clients and patients who are living with Parkinson's in Southwestern Ontario. For those of you who don't know Dr. Jenkins, she has a fascinating history, which I found out a little bit about yesterday. You were a physiotherapist prior to becoming a neurologist. Is that correct, Dr. Jenkins?
Yes, that is true. And I worked with people who had Parkinson's back then too.
And I'm assuming that drove your desire then to be not only to become a physician, but to become a neurologist?
Yes, it did. That is true.
Wow. And you got your MD in neurology through Western University in London?
Mm-hmm.
So local person, which is wonderful. You know the area, you know the folks, and then you have this interest in motor control in Parkinson's disease, from what I understand.
Right.
And you're the, is it correct, the head of the motor movement disorders clinic and associate professor at Western?
Yeah, I'm a part of the clinic. There are three of us involved in the clinic. Yeah.
Excellent. Well, welcome. Thank you again for your time today. I know this topic is really not only relevant, but very interesting to our folks with Parkinson's throughout Southwestern Ontario. And actually, we have folks from all over Ontario joining us today. So I would like to welcome, before I just turn it over to Dr. Jenkins, a couple housekeeping items. Everyone is on mute. That's just to save background noise and our bandwidth. So if you have a question for Dr. Jenkins, please feel free to ask it in the questions box, which I will be monitoring and bringing questions forward towards the end of the presentation. Also, if during the presentation you'd like to share your experiences with others or ask a question of other Parkinson's patients online that are sharing their experiences, please feel free to do so in our chat box, which is open to everyone. So without further ado, and barring any technical issues, I'm going to turn the presentation over to Dr. Mary Jenkins, who we welcome and look forward to hearing from.
Thank you very much, Mark, and thank you for inviting me to do this talk. I hope you can see my presentation okay. I'm just moving a few things around. Sorry about that.
That's coming up well.
Okay. And there, that should be on the right format.
It's perfect.
Thank you very much for asking me to give this talk. Sleep issues are very common in Parkinson's. It's a big part of what we deal with. I wanted to review some of the common issues that occur in sleep in Parkinson's, and then talk about some of the reasoning why these issues occur, and more importantly, talk about how we approach them and what kinds of things we can do to improve them. So the four big topics that I wanted to talk about were insomnia, which is really difficulty falling or staying asleep, restless legs syndrome, REM or rapid eye movement sleep issues, and then hallucinating. And so we'll deal with each of these in turn, and at the end, I'm happy to answer any questions. So as I alluded to, sleep issues are common in Parkinson's. They can occur in up to 75% of people, particularly in later stage Parkinson's. So a common thing that I hear from patients. The causes of sleep issues in Parkinson's are partly due to loss of brain cells in the brainstem and the thalamus in the sleep centers, and so those cells and the chemicals or the neurotransmitters associated with them are not working as well as they should. And when people have done sleep studies in Parkinson's, they do find that sleep is not as efficient, so frequent wakenings, difficulty falling asleep, not a good quality of sleep. In particular, deep sleep, which is stage 3 and 4 sleep, which is important for memory and learning, tend to be less among people that have Parkinson's. And then the idea of waking up frequently in the night are patterns. And so important to deal with sleep because it certainly can impact everybody's quality of life, physical and cognitive functioning, as well as mental functioning too. So it certainly has a big impact all around. So I wanted to introduce each of the topics with a case study, and I'm sure you can all relate to Betty, who's had Parkinson's for 10 years, and she is meeting me in clinic and says, I'm having difficulty sleeping. So what else would I want to know about that? So on asking her, she has actually difficulty falling asleep. I'm sorry, she's able to fall asleep, but she's waking up often in the night. And so the question is, why are you waking up? And she said, well, I have to go to the bathroom. I have to pass my urine. And so up to the night, which is a common issue many people deal with. Once she is awake, then she isn't able to get back to sleep because she feels uncomfortable. And when I explore that a bit further, the uncomfortable is related to her tremor and difficulties rolling over in bed. So when we think about insomnia, there are always a number of different questions. This poor fellow can't fall asleep because he's just laying there awake. So often it's a little bit tricky to figure out what the problem is, but an important part of coming up with the treatment. So in insomnia and Parkinson's, there are a number of questions that are important to be aware of that hopefully your physician's asking, or certainly if you're thinking about it, you can add that. Insomnia is difficulty falling asleep, staying asleep, or getting back to sleep. And as I said, it can be to do with loss of brain cells and the chemicals in the sleep centers in Parkinson's, but it also can be related to a number of problems we can treat. So is it part of motor symptoms of Parkinson's, like Betty? Is it the tremor and trouble rolling in bed? And then I will think about things like how I can change the Parkinson's medication so that you're getting doses through the night. Is it to do with what we call the non-motor symptoms of Parkinson's? So things like mood issues commonly affect sleep. Is it to do with being up through the night because of urinary frequency? Obstructive sleep apnea, although it can be related to a lot of different causes, also occurs more commonly in Parkinson's. And as people may know, people with obstructive sleep apnea, there are a number of treatments. The most common is wearing a mask at night to help with breathing. Is it actually to do with the medications? So unless the problem is motor symptoms at night bothering you, we'll often move the Parkinson's medication away from sleep time. And certain drugs, in particular, sertraline and selegiline, can actually affect your sleep quality. So we might think about stopping these medications or cutting back on them. And then is it something that's really not even related to the Parkinson's? So are you having pain at night? Are you, as a few of us do, stay up late at night watching TV, working on your computer, not trying to maintain a regular routine, and we call that poor sleep hygiene? Or are there other medications causing it? And then, as I alluded to, I'll be talking about other particular sleep problems in Parkinson's that can affect it. So when I hear about sleep in Parkinson's, it's important to go on a hunt to try and figure out what the causes are and then look at the treatments. But if all other causes are excluded, what do we do next? So we've looked at everything. It doesn't seem to be part of the non-motor symptoms. It isn't a pain syndrome. It's not related to medication or things like that. And there you are lying there. So how can I help you out? So one of the things that we will think of next is the idea of sleep hygiene. Are you going to bed at a consistent bedtime, waking up at the same time? Is your bedroom comfortable? Is the temperature comfortable? Is it quiet and dark? Are you avoiding screens for an hour before bed? So the sleep experts will talk about actually taking your TV out of the bedroom, certainly at least turning it off. We're often quite tied to our smartphones these days, but try to keep them either out of the bedroom or turn them off 1 hour before sleep. The reason screens are a problem is because it's giving light um, through your eyes to the sleep centers, and your brain is saying, wow, it's now daytime, time to wake up. So the screens give your brain an inappropriate signal that it's actually light or it's morning time. So you want to be in quiet light, reduce light before falling to sleep. And then everyone knows the food and drink, avoiding caffeine. Alcohol is a bit of a tricky one because people will say, well, if I have a half a glass of wine, I can fall asleep easier. The problem is alcohol actually interferes with the quality of your sleep. So best to avoid it before bed. And then we know that certainly exercise, physical activity in the day can help you sleep. So being active certainly helps tire you out physically, so your body's able to fall into a sleep pattern. If we've done all of that, you've improved your sleep hygiene, we've looked at things in particular like mood. So many of you will know that mirtazapine is one of my favorite mood related pills because it also helps with the sleep. But if we've done all of that, we've improved sleep hygiene, then medications such as melatonin, which is a natural non-prescription medication, can be helpful, and so certainly something to think about there. And if that isn't working, then there are other prescription medications. Trazodone has become more popular and felt to be quite safe, particularly in problems such as Parkinson's. And then other medications we can use, in particular benzodiazepines like Ativan or Razapam, but just caution with them because they are medications which can affect memory, can affect balance, and so we have to use them with caution. Okay, so that's kind of our first topic. I wanted to move on now, and I'm talking to Brenda. And she's had jumpy legs at night for the past year that's interfering with sleep. And I'm like, that's an interesting one. What is that? When I ask her, she says that her legs have a painful crawling feeling, and she has trouble keeping them still. She's kind of moving around, tossing, turning. If she gets up and walks, then the feeling improve. It's always worse at night, although she's been, pre-COVID sitting in a theater or on a long car ride and been aware of it then. So what I'm talking about here is something called restless legs syndrome. And I'll just talk a bit about what it is, because it's often hard to distinguish from other problems, and becomes important because we will treat each of the problems in a different way. Restless legs has four, really five cardinal features. There has to be an urge to move. So you want to move, you want to move your legs, and it can be arms as well as legs. There's an uncomfortable feeling in the legs. It's worse with rest, sitting, lying, and it gets better with moving around, especially getting up and walking, and it's always worse in the evening or night. And the type of feelings people can have are this need, this urge that I have to move. But with it comes different types of things. People can say it feels like spiders are crawling on my legs or bugs are crawling on my legs. It can be pain, it can be a tingling or an electrical shock feeling. So there's a number of different feelings. And because it's a strange feeling, like someone, said, well, I didn't want to tell anyone because I felt like I had bugs crawling on me. And I thought, why do I think I have bugs crawling on me? And so often people don't bring it forward because it's often a bit of an unusual sensation. And then the other thing that I'm going to ask people about, as well as restless legs, is something called periodic limb movements of sleep. And the reason is that both of them, although they aren't the same thing, often occur at the same time. So periodic limb movements of sleep are involuntary, intermittent stereotype movements that are occurring in sleep, typically not while you're dreaming. So REM is rapid eye movement or dreaming time. And the person with the restless legs is very aware of them. The person who has periodic limb movements doesn't really know about them. It's the bed partner who is often awake. So you're asleep, your legs are moving in a repetitive pattern, and your bed partner is not able to sleep because of that. And also, it can, though, cause you to wake up and you don't really know why you woke up, just that something woke you up. And we know that restless legs can occur not only in people that have Parkinson's, but in other illnesses. Although if you have Parkinson's and you have other problems, it can certainly add to the difficulty. And so important to screen for those. Kidney failure, being on dialysis, or even having kidney problems can add to it. Any kind of pain syndrome, back pain in particular, being quite common. Having a low iron, so we'll, if there is restless legs, certainly being aware of iron as being a cause is important. Certain medications, and then as I've said, certainly among people that have Parkinson's, it is more common. So as I said, kidney pain syndromes in particular, peripheral neuropathy, where the nerves going to your feet don't work as well and have a tingling or an uncomfortable pain problem, back and leg pain, low iron, pregnancy is another cause. And then medications, one of them is dopamine blockers, which we don't typically use in Parkinson's because, as you know, in Parkinson's, dopamine is less than ideal, and we're giving drugs to actually boost dopamine, but people who are on dopamine blockers are aware. And if people have been on opioids, pain medications, withdrawing them can be a problem. In Parkinson's, people always wonder, should we even call it restless legs? Because it may be simply that your Parkinson's medication isn't adequate and you're getting wearing off in the evening. And there is a question of whether it is truly restless legs or wearing off, although it certainly fits all the classic symptoms of restless legs when it occurs in Parkinson's. And then there are other leg problems that can occur, and it's important that your doctor is aware of them because there are going to be different medications you can use to treat them. So this fellow has come into his vet saying, well, it only happens when I rub my tummy, so it's not restless legs. So other things, as we talked about, these periodic limb movements, which your legs move spontaneously. Restless legs often does occur with that, and we do treat them in the same way, but just to be aware of what's happening there. Something called akathisia, and akathisia is an urge that you want to get up and pace or walk, and it's more of a sort of central feeling in your whole body, not with this sensory or uncomfortable feeling in your leg. And akathisia is often related to things like anxiety or other psychiatric issues, and obviously has a very different way of treating it. Nocturnal myoclonus are these rapid lightning-like jerking movements. So periodic leg movements are almost like a sort of bicycle type of movement, where myoclonus is your leg just jerks rapidly. That does occur more often in people that have Parkinson's and people who don't. Also occurs with other medical issues too, and a different way of treating that if it's a problem. We often don't end up treating nocturnal myoclonus unless it's really interfering with sleep. Leg cramps are very common, and I think all of us at some point in time have had leg cramping. Again, very different way of treating it. It's often related to being dehydrated, but can occur without reason, and there are different ways we would manage leg cramping. And then other pain syndromes, because if it is a pain syndrome, then we're going to focus more on the pain than on an actual restless leg treatment. So how do we treat restless legs and periodic limb movements? Well, first of all, non-medication treatments are important. So we are going to look at and try and treat sleep hygiene factors like avoiding caffeine and alcohol, replacing iron if it's low, treating any pain syndromes, and then things like warm baths, gentle exercise or stretching in the evening, trying to find other factors. Somebody I follow says if he can get into a good book, then he's not as aware of the restless legs. So other strategies that don't involve medication are important. And then medication wise, the treatments are really medications that we'll often use in Parkinson's. The dopamine agonist group, so pramipexole or Mirapex, ropinirole or Requip, the reticutin patch or Nupro are medications that are often quite helpful. They're a little bit better than levodopa because they last longer, although there are other side effects, and so your doctor may choose to stick with something like levodopa. These drugs tend to last for maybe 7 to 10 hours, and so often take you through the night. Levodopa can be used, and it can be used on a PRN or as needed. So, there are people I follow who say, well, I'm pretty good at night, but if I have to go on a long car ride, my restless legs is really bothering me. And so then levodopa can be used on an as needed because it works quite quickly, lasts about 4 to 6 hours, but has a fairly rapid onset. And then medications used typically for pain, so you may have heard of gabapentin, pregabalin or Lyrica. These drugs often are quite effective and are being used more commonly with good effect to deal with restless legs, and particularly if there is a painful component to the sensation, that can be quite helpful. So I think that's my run through restless legs. Changing topics. I'm coming on to a new, I've actually two cases. This is a true story of a 60-year-old man, Bradley, fell asleep when he was on a transatlantic flight, obviously pre-COVID. Started punching and kicking in his sleep towards his seatmate. He woke up, he kind of briefly remembered a dream of fighting animals in caves, but then he forgot about it. And by the time he arrived in his flight, he really didn't recall what the dream was about and was unaware of what had happened. He said he's never had that happen before, but his wife, when she's called, said he has been doing this off and on for 2 years. Another gentleman, Baco, with Parkinson's, is coming in with what he's calling bad dreams. His wife's quite concerned because he's kicking and punching at night and she's worried about being injured. And on one occasion, he actually fell out of bed, threw himself out of bed. And when he fell out of bed, he woke and she said, what was happening? And he said, I was running away from bad guys who were chasing me. Usually, though, he doesn't wake up in these. And his wife, when she asks him the following day, he says, I don't know what happened. I don't remember any of that. So what I'm talking about here is REM, or rapid eye movement sleep behavior disorder. This is, and it can be associated with vocalizations like yelling out in the night or screaming or swearing. Movements, punching, kicking are quite common, kind of lurching out of bed. And it's usually associated with some kind of scary event happening. And the dreams are typically not remembered, and it's the bed partner who's reporting this. So, you know, often the person I'm seeing says, no, I don't have any sleep problems. And then their bed partner pipes up and says, well, last night you were kicking and punching in your sleep. And the typical dreams are, it's quite curious because it's somewhat cultural and also related to your experience in life, but it's often being chased by an animal or in some kind of fight or chasing and or being chased by bad guys. So usually a very frightening dream that is only recalled if you wake up right in the middle of it. So how do we diagnose it? Well, it turns out that really the history is the key, and the history has to come from the bed partner, who can say, here's what is happening at night. Sleep studies also can be helpful in a diagnosis. As any of you know who've tried to have a sleep study, there's often quite a long wait list, and so it's difficult to get a sleep study quickly, but it can be quite helpful if there is a question of a diagnosis. Brain imaging doesn't help with the diagnosis, and really any kind of lab test. It's really down to the story of what happened, and it becomes important, as you'll see with our next topic, that dreaming can occur in various forms in Parkinson. So who's affected? Well, we know it's men more than women, typically in the 40 to 70 years, but the range can be higher. In young people, we think it's really more related to other sleep problems such as narcolepsy or depressants. In people older than 40, it seems to be more associated with the alpha-synucleinopathies or the Parkinsonism. So alpha-synuclein, as many of you know, is the abnormal protein that we see in Parkinson's and some of the Parkinson's related problems. And it is much more common with people with Parkinson's and with other neurodegenerative problems. So in particular, Parkinson's, Lewy body, multiple systems atrophy, less common, but it can occur in people that have things like Alzheimer's, Huntington's, multiple sclerosis. So other entities certainly can be involved. And in Parkinsonism, REM sleep issues are present in 25 to half of people with Parkinson's and with Lewy body. It actually can start up to 10 years before Parkinson's occurs, and it's much less often in the young onset Parkinson's than in older. So in young onset, we think overall the average is about 25 to 50, but in young onset, much less common. In older onset, much more common. And in people who are having REM sleep problems, if they have had them for 15 years, they have a very high chance of going on to develop Parkinson's. If it's been only for 5 years, they have about a 30% chance. So we know that REM sleep problems are often one of the biomarkers, we call them, or warning signs of Parkinson's, that many people have them prior to being diagnosed, or even prior to having any motor symptoms of Parkinson's. The treatment, well, the first treatment, as long as someone is not injuring themselves, is to protect the bed partner. So separate beds, separate rooms, hopefully sleeping on a couch that's a bit longer than he is sleeping on. And if they are having difficulty with throwing themselves out of bed, then you want to make sure that the bed is safe so there aren't a risk of injury. In most people, it tends to be more calling out and occasionally flinging an arm, and for that, I think separating beds to avoid injury of the bed partner usually works. But in some individuals, if it's becoming more of a problem, then we have to look at other treatments. We also want to look at drugs that can be causing symptoms. So antidepressants can be a risk factor, and so moving them to earlier in the day, not taking them at night, can be helpful. And then the monoamine oxidase inhibitors, so rasagiline, legiline, and sulfonamide, can worsen REM sleep problems if you have that issue. In terms of medication treatments, the first-line treatment that we'll try is melatonin, and in some people that's effective. I have to say it's probably a smaller number of people who respond, but it's very safe, natural product that we aren't as worried about side effects with. And in other people, if we do need a treatment, Nazepam works very well. We would try to start it at the lowest dose we can, and it usually will eliminate the acting out dreams completely. So it's quite effective. One thing, though, that we will sometimes try is certainly even adjusting your Parkinson's medication, in particular levodopa, can actually be helpful in improving the acting out dreams. And then other medication which is used more for memory difficulties. If it's being added in for that, may sometimes help. Although really, melatonin and clonazepam are the mainstay treatment, and as I said, clonazepam is quite effective in treating REM sleep issues. There are other sleep behaviors that can be, that people can question, is this a REM sleep issue? Is this another issue? And so other things are night terrors or panic attacks related to PTSD or anxiety issues, can cause some acting out of behavior. Nocturnal seizures, certainly seizures are very uncommon in Parkinson's, but it can be associated with other illnesses. Things like stroke in particular can often be associated with seizures. So if it seems to be more of a seizure-like activity, and the sleep study can help with that, and also from the story. Nightmares and sleepwalking, people can sometimes have a bad nightmare, and there are people who are predisposed to sleepwalking. And then it can be not that people are acting out dreams in sleep, but if there are cognitive issues, they're up wandering at night and they aren't as aware of what the behavior is. So again, important to get a clear history of what's really happening. And if there are questions, then sleep studies can be quite helpful. Okay, so on to my last case. This is Pablo, and he's had Parkinson's for 15 years. He was previously doing quite well, responding well to treatment. His son calls you and says, Pablo called the police last night because he thought people were breaking into the house. So obviously a very concerning, frightening thing. And when you meet with Pablo to talk about this, he states that in fact he started having some hallucinations or seeing things at night for the previous 2 years. These in the past had been really not scary to him. He'd seen like a dog or a cat or a mouse running across the floor, but he had also been having some dreams that were bothersome, and he was remembering them. So these are different from the REM, from the REM sleep issues. These are vivid dreams that he remembers the following day and are bothersome to him. So wanted to talk a little bit about hallucinating and vivid dreaming or nightmares. These are often linked. What in Parkinson's, about 40% of people may have some hallucinations and or vivid or scary dreams. Tends to occur more commonly later on in the course of Parkinson's, and it can often start first with nightmares or bothersome dreams that are occurring, and that's a little bit of a warning sign that I need to be watching for other things that could occur. When hallucinations first occur in Parkinson's, they're often not very frightening. As I said with our case, they're often things like a cat or a dog or a child or a bug on the floor, but something not scary. And they're always very, very vivid. People can tell you the color of the cat or what the child was wearing, like quite real, but as I said, not frightening. These can then progress to become more frightening, and as they become more frightening, they're often larger, so adults rather than children. or bothersome people in the house that you can't get rid of. This can, if it's untreated, and so we do want to watch this, go on to ideas of having superpowers or grandeur thoughts that aren't real. And finally, again, this is a progression. People can start to develop paranoid ideas, fears that people are plotting against them. These two are quite uncommon, but they can occur. So if we're seeing difficulties with hallucinating, then we want to be aware of that and trying to make changes to prevent it progressing further. In terms of why hallucinating occurs, there are a number of different things. One of them can be to do with vision being not as clear. So if people are having, you know, cataracts, retinal pathology, that the vision isn't occurring, that often tends to trigger it. Having sleep issues, and we're obviously talking about sleep issues, can predispose. And then the brain changes, the chemical and the cell loss changes in Parkinson's also can predispose you to hallucinating. The big thing is and then, you know, as people get older, there's a higher risk, and if there is issues with cognitive impairment, higher risk. But the big factor that we can change or that we need to be aware of is that a lot of the Parkinson's medications can certainly contribute to that, and modifying the medications can be very helpful. So this is kind of a list of the ones most likely to cause hallucinating all the way down to the least likely. Anticholinergics, trihexyphenidyl, is the one that's most commonly available in our region, and so it's a pretty bad actor, and so we try to not keep people on that medication because of the risk of hallucinating. Mantidine being the second line one, and these two medications aren't used as commonly, but they do have their roles. So mantidine can be quite helpful for treating dyskinesias, and so we may have people on it for that. The monoamine oxidase inhibitor, so the class of drugs like sagilin and sulfonamide are kind of next on the line that I would be concerned about, and then the dopamine agonists, and last levodopa. So certainly to be aware that the medications can be a factor here. So in treating hallucinations and vivid dreaming, the first thing is to screen for acute causes. So urinary tract infections are probably the most common thing that we want to rule out first. So if you're having hallucinating, I'm probably going to ask you to follow up with your family doctor to have any infections ruled out. Certainly other blood changes like low sodium or potassium can also lead to hallucinating. So important to have that kind of thing ruled out. Any new medications may also be a risk factor, and so I'm going to ask, have there been any new medications added? Once we've kind of screened for infections or other predisposing factors that are reversible, then I'm going to look at what you're on for treatment and try to reduce or get rid of all of the other medication except for levodopa, carbidopa, the levocarb. So we're going to try as much as we can to simplify down to levodopa. Sometimes we don't have to get rid of other medication, but it's simply reducing it can be helpful as well. Moving it away from bedtime can be helpful, so changes in that. If we've done everything else, then trying to reduce the levodopa, especially at night, can be key to help. So in the evening or night. And if there's no improvement, we've kind of done everything, and maybe things are a bit better, but still happening. Medications can be added, in particular the medications that are used for memory issues, as well as a class called antipsychotic. And antipsychotic is, the word comes from the fact that hallucinating is a form of psychosis. So in Parkinson's, only really two of these are safe, quetiapine and clozapine. The other antipsychotic medications block dopamine to an extent that it affects the Parkinson's. So we generally, if we needed to, think about adding in one of these. This is a new drug that's available in the US and probably will eventually come to Canada, that is also used for hallucinating. But again, the principle is to try and modify what people are on first, to try and reduce that before we would start to add in other things. So in summary, as I talked about, kind of four big issues of sleep issues in Parkinson's, insomnia, so the difficulty falling or staying asleep. Look for and treat reversible causes, right? Mood issues, bladder issues, pain issues, other medication issues. Really a good focus on sleep hygiene, avoiding screens before bed, having a comfortable temperature in your room, doing some exercise in the day. Medications, as I said, if needed. If we've kind of tried everything else, then starting first with something like melatonin, and then maybe trazodone, and then others as need. Restless legs, first of all, come up with the diagnosis, make sure that it is in fact restless legs and it's not leg cramping or leg pain syndromes, and or other leg movements, because we're going to treat them in a different way. And then usually adjusting the Parkinson's medication deals with that fairly effectively. With REM sleep behavior issues, again, diagnose, make sure that's what it is and it's not something else like anxiety issues at night or sleepwalking, or it's not really, they aren't really asleep, they're out wandering at night. So just to make sure what it is. Dealing with safety measures, if it's only occurring at a mild level, separate beds, ensure that the bed is safe for the person who has it, and if needed, then add in medications, and we talked about melatonin and clonazepam being the two. And then lastly, hallucinations and vivid dreaming, again, diagnose the issue, be aware of the issue, treat any infections, change medications as we can, to try and reduce any medications which can be adding to the problem, and then adding medications if needed. And that's my talk. So thank you very much, everyone, for listening. I know Mark has some questions, and I'm happy to address any of those questions.
Absolutely. Thank you, Dr. Jenkins. That was so great. We do have some questions. We've had questions coming in both through the question panel and also through emails. So I'm going to start with one that came in actually last night with email. And the person asked, what aids can you suggest to help turning over in bed during the night? other
Mhm.
than waking up your partner for a push or a pull.
Yeah, that's a big one. So, certainly I would involve my occupational therapy colleagues to help out with that and to have them evaluate things. But there are bed rails that can be helpful, overhead, um, like a bar overhead that you're able to grab onto, a bar at the side of the bed, um, or having either satin sheets or satin pajamas, not both, because if you have both, you're just going to slide right out of the bed. But having either satin sheets or the satin pajamas can just make it a little bit easier to slide. And often you have to sit up first and then move to roll, because just rolling on its own can be difficult. People also have tried having a rope at the end of the bed that's up by your side that you're able to kind of pull on to help pull yourself up. So those are ideas. I would certainly involve occupational therapy, though, to help out with that.
Absolutely. Thank you. And you made a great point, folks. Just we are asking Dr. Jenkins questions, but it is always great. It always recommended to go and speak with your family physician or your neurologist specifically about this. These are very general questions. So the next question was online, and it says, I was changed from lorazepam 1 milligram to clonazepam zero point 0.5 milligrams, which is making me dream, act out, and I'm seeing people. I'm also not sleeping. What
Hmm.
could you suggest or recommend?
Wow. So that's kind of a big one. I guess the question is, why were you switched? So that's the first thing, and I would speak with your family doctor about that. The other thing is, it's likely not the clonazepam that's causing you to dream or see things. It's likely other medication. So you would want to have a medication review, maybe some changes, maybe moving the other medication away from bedtime. That would be my advice. So I think review your medication with your family doctor or your specialist.
Okay, great. Next question came in by email, and the person asked, "How effective are sorry, I can't even speak here today. Naturopathic or holistic solutions for sleep issues, and do they have any adverse effects that you know of?"
Okay, well, that's a big question, but I certainly melatonin is a natural or naturopathic medication to help with sleep. There are other medications that are natural out there. I would always want you to check in with your doctor on the contents. So, for instance, there's a natural product out there for Parkinson's, but it actually is levodopa, just in another form. So some of the natural products do contain medications that can have adverse effects. But I think, I'm certainly not opposed to them. I would want to know what's in them and what you're taking. But I think there are some, and probably a lot of them will contain a melatonin type of product, and I would certainly be supportive of that.
And as a follow-up, someone came in with, of course, this one's a popular one. What about CBD oil helping
Oh
sleep?
my goodness. Oh dear. If you have any children in the room, send them out immediately. I'm not opposed to CBD. I have not had a lot of people that I follow that have Parkinson's have wanted to try it. I'll just tell you my cautions. It can worsen hallucinating. So if hallucinating is a problem, then I would not want you to try it. If hallucinating is not a problem and there aren't other issues, I'm not opposed to people trying it, but there has not been good obsessed with it. It is very good at treating pain. So if pain is a problem, then alleviating the pain may help people sleep. But I would want you to check with your doctor first on what other drugs you're on, and to make sure that there's not a risk of hallucinating and a risk of interaction with your other medications. Okay, anything else, Mark? Oh, I think I've lost Mark. Hello?
Can you hear me, Dr. Jenkins?
Yes, yes, now I can.
Can we hear? Yes, you are. Okay, good. The next question that came in says, should you wake someone up who is having active dreams where they are flailing about?
Yeah, certainly if they're going to injure themselves, yes. Like if you think they're going to throw themselves out of bed, waking them up, again, is fine if there's a safety issue. It's not going to help though in the long run with managing it. So you can let them sleep through. They're often very bothersome to the person who's beside them. And if there's risk of injury, either to the person acting out the dreams or to the bed partner, then I think safety always has to come first. And so you may, want to wake them up, but waking them up doesn't really help them. And it's probably going to be quite anxiety provoking for them because they're in the middle of a very scary dream.
Right. Okay. And the next question came in online as well. Would you recommend taking magnesium for the restless leg syndrome?
Oh, yes, yes. Thanks. I'm glad somebody added that. Yes. So magnesium, some people find is actually quite helpful for restless legs. So it is another thing you can try. Yeah. Warm baths, magnesium can certainly help, and not a medication. But yes, I would agree with that.
Okay. And then we actually have a couple COVID questions,
Oh
which
dear.
are, that's okay. They're nothing too difficult. The first one was, are you seeing or hearing about more sleep issues, specifically linked to anxiety and depression since COVID began?
Yeah, I would say that's true. I mean, it's been a very, very difficult time for everyone, and everyone's anxiety levels are up. So people are not sleeping as well and they're not doing as well generally. So I would agree with that. COVID has really wreaked havoc with us all. Yeah.
Right. And the follow-up COVID question was, how are the specialists rebooking appointments at this time?
Oh, that's a good question. So, most of us are trying to do uh, calls virtually if we can, to limit exposure to people coming into the hospital. But certainly we can see people who are having big issues that we can sort out over the phone. And so we're trying to work with the virtual route, either telephone or video if we can, and if need to, then we can certainly bring a limited number of people in to the hospital.
Excellent. And a follow-up to the magnesium question is, what dosage of magnesium do you recommend?
Yeah, that's a good question. It's the usual, and somebody's asked me this recently. I'm not exactly sure. The pharmacists have it prescribed in kind of a low dose, and I would go with the lower dose. So ask your pharmacist about that, the lower dose, not the higher dose. Any kind of products like that, you wouldn't want to go with the higher dose, but I don't know the exact strengths that it's coming in. Sorry, I
Okay.
can't help you better with that.
No, that's one of those you need to ask your family doctor or your neurologist.
Yeah.
Dr. Jenkins, it's always a pleasure to speak with you. And I know just from the amount of questions and I get to see from the backside how many people are attending. And this has just been a phenomenal presentation today. I know so many people were interested and looking forward to it, and you certainly didn't disappoint. You're a fantastic speaker and a good friend to us. So thank you on behalf of all of us for joining us today and giving your knowledge and answering the questions, and helping everyone through their Parkinson's journey. It can be scary. It can be feel like you're alone sometimes. So having folks like you come out and join us and give us a bit of reassurance and answer those questions certainly makes such a difference to our clients and our caregivers and our care partners. So on behalf of all of us, thank you so much for your time today and taking the time to put together that presentation.
Oh, thank you, and thank you all for coming. Have a great day. Enjoy the sun. That'll help you sleep later on this evening.
Absolutely. A little bit of a commercial for Parkinson's Society Southwestern Ontario. Please, everybody, remember we do have resources available to you, including support groups, our coffee clatches, counseling services, and referrals. So please contact us at parkinsonsociety.ca if there's anything we can do to help make your journey a little better. Thank you for joining us today. Stay safe and stay healthy.